just about a minute after 10:30, so I think we'll go ahead and get started. Welcome to the third webinar within the FPMRS Fellows webinar series. This is a joint effort during this endeavor. I'm Will Winkelman, I'm the third hospital, and I'll be moderating the session today. The webinar is Diagnosis and Treatment of Bladder Emptying Problems in Women, presented by Dr. Victor Nitti. Dr. Nitti is the professor of urology and obstetrics and gynecology and the Shlomo Raz Chair of Urology, as well as the chief of the Division of Female Pelvic Medicine and Reconstructive Surgery and the fellowship director at the David Geffen School of Medicine at UCLA. Our panelists today include Dr. David Ginsberg at USC and Dr. Christopher Tarnay at UCLA. Dr. Nitti will present for about 30 to 40 minutes, and during his presentation, we'll have a few clinical cases that the panelists will discuss. We'll then open up the discussion and have the panelists reflect on the clinical cases as well, and then take questions from the audience. In case anyone is here for the first time, I'd like to briefly review some housekeeping items. The webinar is being recorded and live streamed. As a participant, you'll be on mute, but please use the Q&A feature to ask any of the speakers questions. We'll try and address as many as we can within the hour. Use the chat feature if you're having any technical issues. The AUGS staff will be monitoring that throughout the webinar. At the end of the webinar, you'll be prompted to complete a brief survey and provide some feedback about the session so we can improve on these going forward. And then I just briefly wanted to mention about our next webinar, which is scheduled for Tuesday, April 21st at 5 p.m. Eastern Time, and that's the Anatomy of Level 3, Surgery, Prolapse, and Operative Failure, and that'll be presented by Dr. Delancey. You can visit the AUGS website to sign up for that. On that note, let me hand this off, and we can start our presentation.
Great. Well, thank you so much, Will. It is a pleasure to be here. I want to thank AUGS, SGS, and SUFU for giving us all the opportunity to do these programs for you. It's also a great pleasure to have as the panelists on this my two friends and Dave Ginsberg, my longtime colleague, and Chris Tarnay, my partner. So hopefully we will give you all something to think about as we talk about the diagnosis and treatment of bladder emptying problems in women. I have just a couple of disclosures, which are right there up on the screen, nothing that really affects this lecture. So I think it's really important as we start to think about bladder emptying problems, and I prefer that term over retention. I mean, to me, urinary retention is when somebody can't void, almost can't void at all. So I like the term bladder emptying problems or incomplete bladder emptying, although sometimes bladder emptying is not incomplete and there's still a problem. I love the functional classification of voiding and storage dysfunction because this really, it's a very simple system. It can be applied to diagnosis, it can be applied to treatment, it can be applied to urodynamics, etc. So we can think of lower urinary tract dysfunction as either a failure to empty or problem with emptying, or a failure or problem to store. And either of those can be due to bladder dysfunction or outlet dysfunction. And of course, we can have combinations of both. So if somebody had, for example, we're talking about emptying problems, a failure to empty due to bladder dysfunction, that would probably be because there's some degree of Detrusor underactivity. If it was outlet dysfunction, it would mean that there's some degree of obstruction. It's important, we're not going to do a big neurophysiology talk, but I like to just go over some brief basics of the neurophysiology of micturition. If you think about normal voiding, the first thing that happens is that the striated sphincter relaxes. So some people have issues just because they can't relax their striated sphincter. That happens most commonly in situations where you have a person who has difficulty voiding in public. They can't relax. The next thing that happens once the sphincter relaxes is the bladder or the detrusor contracts. Then the vesicle neck and urethra open, and there's an onset of urine flow. And as we know, this is a coordination between the pontine and sacral micturition centers. Now, detrusor function has been defined by the International Continence Society. And these are, if you look at these definitions, they are very general. They don't have any specifics on them. For example, when we look at normal detrusor function, it's a voluntarily initiated continuous contraction that leads to complete emptying within a normal time span and in the absence of obstruction. Now, there's no pressure or flow criteria. And the same for detrusor underactivity. It's reduced strength or duration. It results in prolonged bladder emptying or a failure to achieve complete emptying, but there's no specific numbers on there. And I think that's very important as we try and understand the differences between bladder dysfunction and outlet dysfunction. And it means we're going to have to think a little bit, and it means we're going to have to individualize a little bit. What's numbers in one patient and numbers in another patient may not necessarily mean the same thing. So if we think about ineffective emptying, if it's a bladder, it's either underactive or it doesn't contract at all. And if it's an outlet, we can have anatomic obstruction or functional obstruction. And we'll talk about the difference between the two. Anatomic obstruction is much more straightforward and I think easy to diagnose. So if we think of the underactive detrusor, what causes it? And you can see up there the different causes. It could be neurogenic, usually from a lower motor neuron or decentralization injury. It could be myogenic, from chronic obstruction or chronic overdistension is a better term. The diabetic bladder, when it develops incomplete emptying and the inability to contract, it may start out as a neurogenic problem in that the patient doesn't sense that she's full, but then as there's chronic distension, it has effects on muscle. There's many drugs that can cause detrusor underactivity. The detrusor does become less active as patients age. And then you can have failure of sphincter relaxation. And I never know where to put this. Is this a detrusor issue or is this a sphincter issue? Especially Fowler syndrome, which we'll talk about a little bit about later. It's really a sphincter problem because it doesn't relax. The sphincter doesn't relax, but the detrusor never contracts. So it's a little bit of both. Here's causes of obstruction in women. And on the left, you see a variety of anatomical causes of obstruction. And I'm sure there's a few more we could come up with if we think about it. And then functional causes. The main difference I think that's important to note is that anatomical obstruction is usually pretty straightforward. You don't need, you can diagnose an anatomical obstruction based on a physical exam or based on an endoscopic or radiologic exam. For example, if a woman has a stage 3 or 4 pelvic organ prolapse and she's not emptying well, there's a good chance it's due to that obstruction. And if you simply reduce the prolapse, you can know for sure. The same after a sling is placed for incontinence. If that patient doesn't void normally afterwards, it's very likely the sling. Functional obstruction, however, can only be diagnosed in the act of voiding. So in other words, if a patient has primary bladder neck obstruction, dysfunctional voiding, we wouldn't be able to diagnose that unless we observe the patient voiding. So that's where our advanced testing comes into play. So that's where, for example, urodynamics is going to be much more important in the functionally obstructed woman or suspected functional obstruction, as opposed to anatomic obstruction. The other issue with trying to sort out obstruction versus detrusor underactivity is there's not a highly prevalent condition. If we go back a slide, you can see there's many conditions that can cause obstruction, but none of these are highly prevalent. In men, when we came up with, when the nomograms were created, it's because there's a very prominent or prevalent condition, benign prostatic obstruction, that allows us to look at large number of patients with clinical obstruction look at them, and then apply, for example, urodynamic parameters to them. We don't have that in women, and all these different types of obstruction can behave differently. Another problem or issue that we have with women is that when we look at urodynamic testing and pressure flow parameters, we know that at least 25% of women don't void characteristically on a urodynamic study. The other thing is that Valsalva voiding is very common in women. Sometimes it's necessary. That's the only way a woman can void. And sometimes it's not necessary, but can augment voiding. So if you can imagine you are in a situation where you're having trouble relaxing and initiating a detrusor contraction, if you have the capability of Valsalva voiding, you may just do that, but it might not be what you do in normal daily life. It doesn't mean you have to do it. It means you were able to do it. So we have to sort that out when it occurs on a, for example, on a urodynamic study. Is that absolutely the way a woman always voids, or was that just as a result of the study? When we think of detrusor underactivity, we can have a weak contraction force, a short detrusor contraction, or an impaired contraction velocity. These probably reflect different pathophysiologies, but investigations on these various causes remain scant, so we don't have great subclassifications of these right now. It's also not uncommon to have combinations of both detrusor underactivity and obstruction. Because we don't have great treatments for detrusor underactivity, we will often, or at least I will often, go after obstruction to try and get a patient to empty better, because I don't have something that's going to make her bladder contract stronger. Symptoms can be misleading. You have detrusor underactivity, you have bladder outlet obstruction. We can have some very similar symptoms, and even overactive bladder can have similar symptoms. Lots of women with overactive bladder will complain of incomplete emptying, not because they really aren't empty, but because they have to void again very shortly after emptying. So symptoms can be tough. Now, women commonly void with low pressures and sometimes with just pelvic floor relaxation. So if we were to obstruct a woman who voids with a low pressure, we may not see the kind of response that we would see in somebody who voids with a normal pressure, or in the kind of response we see in a man. And I bring up men because when we look at how bladder outlet obstruction has been studied over the decades, it's mostly been in men. So here's a woman with stress incontinence, and when we look at her voiding phase here, you can see she barely mounts any detrusor contraction, and this is equal parts bladder abdominal relaxation as it is a rise in bladder pressure. And you can see there's an absolute perfectly normal flow curve. So this patient does not have detrusor underactivity, even though she has very little detrusor pressure to void normally. Let's say we were to do a sling on her and obstruct her. And let's say we made her voiding pressures from 10 centimeters of water to 35 centimeters of water. Well, 35 centimeters of water is not an outrageously high number, but in this patient, 35 centimeters of water is 3.5 times her normal voiding pressure. So we have to consider that and look at other signs that there might be an obstruction. So as I mentioned before, with anatomic obstruction, the diagnosis is often straightforward. I used the examples of pelvic organ prolapse and urinary retention after incontinence surgery as easy things to diagnose, relatively easy things to diagnose. In such cases, urodynamics is often not necessary. We can make that diagnosis on a clinical basis quite easily. So how do we evaluate somebody in whom we suspect they're having a problem emptying their bladder? Well, we're going to take a history. That is going to be our main, the main thing that leads us to suspect voiding phase dysfunction. A physical exam, and sometimes we may find something on our exam that could obviously be a source of that incomplete bladder emptying. Voiding and intake diaries are really most valuable for patients with overactive bladder symptoms, but certainly if indicated, we can use them. Urine analysis, obviously you want to make sure a patient doesn't have an infection, and a post-void residual to see if there really is an emptying problem. Now, just because a post-void residual is low doesn't mean there's not voiding phase dysfunction. And if you still suspect it, then you can move on to something like a non-invasive uroflow. And I would say that in most cases, a normal non-invasive uroflow and low post-void residual almost always rule out voiding phase dysfunction, almost always. Now we have other tests that we might use in specific instances. There are several different urodynamic criteria that have been done to diagnose voiding phase dysfunction, and I'm going to very briefly go through these. I could spend a long time talking about these, but I won't. There are cut points, and the cut points looked at patients with clinical obstruction and patients without clinical obstruction or who were unobstructed, and they came up with these as the best pressure flow parameters to diagnose obstruction. But still, many women fall out of these parameters. There's the video urodynamic criteria, which we described, gosh, it's a long 20 years ago, where we looked at, where we just defined obstruction, radiographic obstruction between the bladder, neck, and the meatus on fluoroscopy in the presence of a detrusor contraction of any magnitude. Now, that requires fluoroscopy. This is the Blavis-Grouch nomogram that sort of used the concepts of each of these. And then the last thing is the Solomon-Greenwell nomogram, where they came up with the bladder outlet obstruction index in women, giving basic chances of obstruction given urodynamic criteria. So they, although it's based on the video urodynamic criteria, you can diagnose obstruction without fluoroscopy. So this is a case that led me to the concept of the video urodynamic diagnosis of obstruction. This is an 85-year-old woman in urinary retention. Does she have obstruction or does she have detrusor underactivity? So first, we're going to look at the urodynamics before we talk about the history. And basically what's going on here is a sustained contraction of 15 centimeters of water. This lasted a long time. Now, in 1991, when this study was done, I would have said 15 centimeters of water, that's a weak bladder. I'm sorry, Mrs. Jones, you have a weak bladder. You're an older patient. Your bladder just doesn't work anymore. But now let's look at the radiographic picture. That little bubble wasn't there before she started to void. That bubble only occurred after she started to void. Now let's look at her history. She had urinary retention only after excision of a distal urethral lesion, probably a urethral carbuncle. And then she needed to do self-catheterization. What this actually is her urethra. It was closed off at the time of this surgery. She was actually catheterizing through a false passage. Interesting case, but what was much more interesting to me was this concept of adding this picture made all the difference in the world, and opening up her urethra allowed her to void normally again. There is an attempt to define detrusor underactivity and try and find some symptoms in women. And this group sort of came up with, for detrusor underactivity, a pressure of less than 20, a maximum flow of less than 15, and a bladder voiding efficiency of less than 90% with clinical obstruction excluded. In other words, patient doesn't have a stage 4 prolapse. So this is mainly for research purposes. How well this applies clinically remains to be seen. Now, I would like to present a couple of cases here today and just talk about the importance of thinking when you do urodynamics. And I'll present each of these, and after I present this, I'm going to open it up to David and Chris to make some comments. So the first one is an 85-year-old woman with incontinence and a very large residual. She was hospitalized for a fall injury, went home, and her main issue is that she's incontinent all the time, but she's also noted to have a high post-void residual. If we look at this urodynamic tracing, we see that she has these involuntary contractions and she leaks with these. They're low pressure and she leaks. And then when she attempts to void, there's just a little bit of flow and really not any appreciable pressure. In this case, I don't think the video is critical, but what we do see is there is some funneling of her bladder neck when she attempts to void, but we almost don't even need the video on this case. Now, what's important about this case? What's important is that this is exactly what happens to her in real life. So I felt comfortable making a diagnosis of Detrusor overactivity and Detrusor underactivity. Yes, you can have the two together. The bladder contracts when you don't want it to and she leaks, but when she wants it to, it doesn't contract. And the important thing for me in making this diagnosis is the patient's symptoms were created. She said to me, yes, this is what happens to me at home. So I would ask my, ask my panelists, what do you do in a situation where you have underactivity and overactivity?
Well, I would have to say, Vic, these are some of our more challenging patients. It looks like she has a fair amount of sphincteric activity as well when she's attempting to void. But I also always kind of take that EMG with a little bit of a grain of salt, just because I'm never sure if that EMG is working optimally with the patches. But she's certainly someone who, the initial first option would be something like pelvic floor therapy. We can get her to retrain and learn how to decrease that sphincteric activity. That may be helpful as an initial step.
Well, let's say she's just miserable with her incontinence and she says, can you do something for me today so that I stop wetting myself all the time?
Well, today I can always put a catheter in her, certainly, but I'm not sure that's what she wants to do long term, but that's always going to be an option for us.
Right, and I suppose if she's a good 85 and willing, then self-catheterization would also help in this kind of a situation.
Absolutely.
She's not in any danger, she's just uncomfortable.
Yeah, so I agree with David. These are really the challenging patients, particularly, and the curious thing is the sentinel event in her, and what was the transition for her to become a non-functional voider. But I think you said something really, so when I first look at this, I would look for a functional outlet obstruction. And I agree with David, it can be really challenging to identify those patients who have urethral spasm or dyssynergia. But and then the other, I think, really important point, and this I think can be really applicable to the fellows, is you made a comment about the reproducibility of symptoms on testing. And earlier in your talk, you talked about the artifactual nature of the testing that we do here in the urodynamics lab. And so this is where I think this is the opportunity for the fellows in particular to really, if you don't have the opportunity in your training program to be present, and you're not doing them yourselves, to be present when your nurses are doing the urodynamics, to really understand the technical aspects of doing it, and to be present to try to understand that if the patient's symptoms truly are reflected at the time of testing.
That is a very critical thing. And I think that if you're not going to be there, and I would say it's always ideal if you are there, that the person doing the study knows precisely what you're looking for. And I think that leads us very nicely into the next case. So this is a 26-year-old woman who is completely healthy. She has no neurologic history. She's absolutely perfectly healthy, but she was found to have urinary retention 4 years before I saw her, when she had a UTI and was found to have an elevated post-void residual. Basically had a leader in her bladder. So she was started on self-catheterization by the doctors that she saw, and she's doing it for 4 years when she came to see me. She has urges to void with occasional flow with a full bladder. So as we look at this study, what we see here is we see, well, and she was filled to quite a full amount. But what we see here is she does have some loss of bladder compliance. Her pressure gets up to around 25 centimeters of water as the bladder fills. She attempts to void, but nothing really happens. She pushes, she strains, her bladder never really contracts. Yes, there's increased sphincter activity, but she's pushing and straining. Nothing really happens. So the study ends. I take the catheter out over here and nothing happens. So the study ends. So what did this leave me with? Well, this left me very unsatisfied. And I actually said the one thing I wanted to do was duplicate her urge to void and the flow that she sometimes has. Because if she is obstructed, that's the only thing that I can, that's what I need to see, what's happening during that moment. So right now, the only thing I could say as well, is this Fowler syndrome? She's not relaxing? Well, it certainly could be, but I wasn't content with this study. So what I did was I brought her back again, and I brought her back 10 days later, and this is what happened. And you can look at this and say, well, it looks kind of the same, but it's not kind of the same. So what we see here is up to here, everything looks the same. But the difference is now when she attempts to void, she generates a contraction. And remember, you have to, when you look at urodynamics, you have to realize that this is a compressed view. So this is actually a 3-minute sustained contraction of 50 centimeters of water. That's a lot. And what we see is, yeah, there's some increased sphincter activity, but she's uncomfortable. And then I pull the catheter, and lo and behold, that small amount of flow occurs. Now I've duplicated her situation. So I believe it's a functional obstruction. And this is where my video was so critical, because if we look at what's going on here, her bladder neck is absolutely closed. So this is a case of primary bladder neck obstruction. And if you're concerned about this, if you notice here, once the catheter is pulled, the sphincter relaxes and there is some flow, but the bladder neck is absolutely closed. So this young lady, it's not a common thing, but she had a primary bladder neck obstruction, was ultimately treated with a bladder neck incision and never catheterized again. So I think that this really drives home the point of duplicating symptoms or duplicating what the patient tells you. The other thing I'll tell you, and I'm going to show this in a future case in a moment, is what, and David mentioned before with increased sphincter activity, I will always, when you have the luxury of video, to me, and we've actually written a paper on this, the video to me is more valuable than the EMG. There's less artifact that's going to happen. And you can imagine when you start to contract your bladder to this level, you're going to be uncomfortable and you're going to start, or you may start to move around, and just moving around will cause that EMG to start to get a little crazy. David, what do you think?
So Vic, I'm going to ask you a question about this. I think you and Chris and myself, we're very fortunate that we have easy access to be able to do video urodynamics when we want. I know that all programs don't have it. All the fellows that are here may be going to take jobs where they may not have easy access, be able to do fluoro or video at the time of their urodynamic study. What would you say to them? Because I think this is a great example of where if you don't have the video, this is going to be a much more challenging diagnosis to make.
Right. And I think I have 3 points on that. The first is sometimes you just want to know if the bladder's contracting. So you may not need video. If that's your only question, is the bladder contracting? You don't need video to determine that. If you do need video, then I think that you have 2 options. One is you can do your urodynamics, and then separately, you can do a voiding cystourethrogram with the hope that what's happening on that voiding cystourethrogram and what's happening on your urodynamics is the same. And I think probably most of the time it will be. And if you did a VCUG on this woman and you were able to get her to void a little bit and it looked like that, I think you could be relatively comfortable. And then the last thing is, if you're really not sure, I think the patient deserves a video urodynamic study and should be sent somewhere where it could be done. But that's those patients where it's absolutely mandatory and you can't use a VCUG are going to be few and far between. But, in places where there's real, it's a real diagnostic center for these types of problems, then it should be available.
All right, let me ask you another question. So at least in our lab, there's usually either myself or the fellow, the urodynamic nurse, and the fluoro tech. So there are 3 people there. We ask the patient to void. And there's always those patients that just aren't going to void with everybody around. And when it's that pressure flow study is one of the rates you really want to see, when you're looking for obstruction, we'll leave, we'll put water on. Do you have any other tricks besides bringing the patient back? Because I just, sometimes you just can't get that patient to void.
I have a trick that I used to do in New York, but I think it's illegal in California, and that would be to have everybody step out of the room and have the patient hit the fluoro when they void. I don't think we're allowed to do that in California unless she has a fluoroscopy license. But that is a trick that you can do. If you don't need the video, one of the nice things in some of the systems is they have Bluetooth, and you can send the patient into the bathroom with a flow meter and do a pressure flow study in private. You can't get the video, but I have done things like in my old setting where I'd step out of the room, and as soon as the patient started to void, I'd either hear it or she would say it, and I'd run back in and step on the fluoro pedal, all kinds of tricks like that. But those are definitely challenging, no question about it. All right, let's move on. We got about 10, 15 minutes left. So utility of urodynamics after stress incontinence surgery, I would say, you have a patient, you've done a sling on, they have obstructive symptoms, they're not emptying properly. I'd say urodynamics is not much help if they're obstructive symptoms. If it's predominantly storage symptoms, and you think that the storage symptoms might be caused by an obstruction, and you think that the sling may need to be revised or the incontinence procedure may need to be revised, that's where it's going to have its most benefit. And we've actually showed that in a study that we published in 2013. So let's talk a little bit, we'll spend a little bit more time on functional obstruction and then Detrusor underactivity, and then we'll go to our questions. So dysfunctional voiding. Dysfunctional voiding, and we see this a lot, and we see it to varying degrees. It's increased sphincter activity during voluntary voiding. One can have an intermittent or fluctuating flow rate. It's involuntary intermittent contractions of the periurethral striated muscle. It this type of voiding can also be the result of abdominal voiding, but in the latter case, you won't get a bladder contraction. And I think that EMG or video urodynamics is required to distinguish between these two entities. This is classic dysfunctional voiding. It's dysfunctional voiding without the video. It's dysfunctional voiding with the video. This patient has Detrusor overactivity here, a sustained high pressure contraction. Yes, her abdominal pressure drops a bit. She has increased EMG activity, a low intermittent flow, and a spinning top urethra. Interestingly, I was recently at Emory with Neil Galloway, and he has a system where he can do EMG on each side of the sphincter, and you can actually sometimes see dysfunction on one side or the other, which I thought was absolutely fascinating. So I think we can study this external sphincter a lot better than we do. But that's not a primary bladder neck obstruction, because this is a spinning top urethra with obstruction right there. I'd like to present this case because this is one of the most dramatic cases of dysfunctional voiding that I've ever seen. Healthy 35-year-old woman, urinary retention after diagnostic laparoscopy. Her retention resolved. She was discharged, went home, and was readmitted a week later with an elevated creatinine and bilateral hydronephrosis. What I will tell you is that I don't think this was done. She had a diagnostic laparoscopy. She was a young woman. I don't think she ever had renal function tests before this diagnostic laparoscopy was done. I think she had a CBC as her pre-op workup. She had no neurologic or urologic history. And before I saw her, she had a complete neurologic evaluation, including a spinal tap looking for protein and MS. This case, by the way, dates back 25 years, 28 years. Creatinine normalized after her Foley was placed. And here is her urodynamics. She has terrible compliance. So changes in bladder compliance can occur with long-term obstruction. She has increased sphincter activity. She attempts to void. She voids, but not very well. A lot of increased sphincter activity, not much increased pressure, but high pressure over her impaired compliance. She has reflux up one side. She probably has hydronephrosis from high storage pressures on the other side. She does have an open bladder neck when she fills, and a more open bladder neck when she voids. So this is the most dramatic case of dysfunctional voiding that I've ever seen in an adult. Now, when you see something like this, the most important thing is we got to protect her kidneys. They're already in trouble. So what we did in this case is we had to lower her storage pressures and get her to empty. And what we did was we started her on self-catheterization and an anticholinergic. Now, I don't think this problem happened a week ago. I think she had this for years, and it was just unrecognized. You don't develop that kind of hydronephrosis from dysfunctional voiding in a week. So we followed her up a month later, and she's doing self-catheterization. But what we notice here is that now she has low storage pressures all the way to 450 cc's. So the anticholinergics are working. She attempts to void, and she still has high pressure, low flow. So she's still a dysfunctional voider, but at least now the situation is safe for her. Then what we did was we instituted the treatment that works for dysfunctional voiding, and that is biofeedback. It's a learned behavior. It's not based on a neurological problem. So we did biofeedback, unlearned the learned behavior, and here she is now voiding with a relatively normal flow. It's still a reduced maximum flow rate, but much more normal. That wacky sphincter activity is gone. She's off anticholinergics. And the problem of dysfunctional voiding has been treated. So these are really tough patients, and this is probably one of the more dramatic cases of dysfunctional voiding that I've seen, and one of the more dramatic success stories of treating dysfunctional voiding without, in the long term, without any medications. Gentlemen, comments?
I would just agree with you. Go ahead, Chris. Go ahead.
Yeah, I have some comments, but I can hold them till the end because I think it's going to speak mostly to the global concept of testing and utility of testing and what type. But I think this is a really great example of, albeit extreme, of where urodynamics can play a really important role for this patient and a history.
Right. And, you know, I looked for causes of her dysfunctional voiding, and this woman grew up in Burma, and the only thing that she told me that was strange was when she was a young girl in school, they would not allow children to go for bathroom breaks. I don't know if that's what caused her dysfunctional voiding. I have no idea. I want to show, this is another almost identical case where it looks like dysfunctional voiding. It's a healthy 18-year-old woman who basically had mostly nocturnal enuresis and urgency incontinence. But this woman had not been worked up for a neurological problem. And she has what looks like dysfunctional voiding. But in her case, because she hadn't been worked up, she got worked up, had a lipoma of her lower spinal cord. So this is a myelodysplastic syndrome that caused it. We could do all the biofeedback in the world. This is caused by a neurological problem. And as such, this is detrusor sphincter dyssynergia, true detrusor sphincter dyssynergia. And that patient is going to need long-term bladder relaxation and intermittent catheterization. Fowler syndrome is something that it differs from dysfunctional voiding because the bladder never contracts. It's an EMG diagnosis, but it's a needle EMG diagnosis to get it exactly right. Most of us don't do EMGs. The best treatment for this is neuromodulation. That's the treatment of choice for Fowler syndrome. It was originally described in women with polycystic ovarian syndrome. The last thing I want to do is I just want, in the couple minutes we have left, I want to go to just talk a little bit about the detrusor underactivity. The problem with the detrusor underactivity is we don't have good treatments for it. So if we think of how can we treat it, bladder related, Valsalva voiding, timed voiding, unfortunately, we don't have good pharmacologic therapy to make a bladder contract stronger. People are working on it. Neuromodulation, I don't believe it really addresses the bladder. That remains to be seen, but because it is approved for non-obstructive urinary retention, my own personal belief is it has more of an effect on the sphincter, like in Fowler syndrome. Reduction cystoplasty, where you have a giant acontractile bladder and you cut out part of it, doesn't really work. Bladder myoplasty, where we wrap the bladder in some sort of muscle, latissimus dorsi, rectus, and then stimulate it with an electrical pulse, doesn't really work. They are working on tissue engineering, where the same idea of extracting muscle cells from the thigh, it's been used in the sphincter. It's also been used in injecting it into the detrusor to try and help it. But that's a little bit, that's still experimental. Outlet related, basically, if there is issues with some degree of obstruction, you can try and treat it. It doesn't make the bladder better, but it might help with emptying. Doesn't always work. And of course, what we often do is circumvent the problem, but these are not, catheterizations and diversions are not often desirable. So we need better treatments for detrusor underactivity. And I'll just sum up by saying pressure flow parameters are not precise. There are a multitude of conditions that can cause obstruction. We need to be thoughtful in our diagnosis. we need to individualize therapy. It's especially true in elderly patients where the incidence of Detrusor underactivity goes up. So I really believe we have to approach these patients individually, look at their history, physical, et cetera, and then try and come up with different ways that we can enhance bladder emptying. Thanks for your attention. Panelists, if you have any more comments, and then I guess we have about 15 minutes to take questions.
So Vic, for the fellows, you were talking about, you had 2 dysfunctional voiding patients. One got a neurologic workup and you found the lipoma. I don't feel obliged to do a neurologic workup in every single dysfunctional voiding patient I see. So can you describe in terms of age at onset, other symptoms they may have, how you decide, or what you find on exam?
I think the difference in that young woman was she had several things going on. Number one, well, first of all, she was relatively young. So that's the first thing, is that, a missed occult myelodysplastic syndrome, not so unusual in a younger person. If she's 70, you're probably not thinking of that, although you could be thinking of a spinal cord tumor. The second thing is she had both Detrusor overactivity, rather severe. It occurred at very low volumes, and she had sphincter dyssynergia, or the failure of the sphincter to relax. So she had both of those things. And then the third thing was she had significant incontinence. So all those things together. Now, if I see somebody who is, let's say she's 40 years old, is having trouble emptying her bladder, has, the urodynamic picture is less dramatic, that person I'm probably not going to send for a neurological workup. So it's age-based, it's severity of symptoms based, and it's severity of urodynamic findings based.
If you had any more comments, and I wanted to pivot to something that sort of was dancing around your entire talk today, and that was, as you were speaking to the fellows, one of the first comments you said was that the 3 of us do have the benefit of having a fluoroscopy unit inside of our center. And as the fellows move through, many of them are going to have the benefit of being a tertiary care center, academic medical center, and they're going to have the benefit of or easy access to fluoroscopy. I think as we talk about bladder emptying issues in women, I think it's really important to know, and you didn't have a slide for it, but I think you stated it, is the vast majority of these, as they're walking into a urogynecology or female FPMRS clinic, are going to have more garden variety, straightforward outlet obstruction, usually anatomic. And as you know, already, whether you're a first-year fellow or getting ready to graduate, these are going to be the lion's share of your patients with either post-obstructive symptoms after surgery or prolapse reduced, or there's going to be something that you can identify with the tools that you have. I think one of the biggest challenges are going to be walking out into a practice setting. And if you're joining an academic medical center, fine, you'll likely have the utility. If you're going to the community, if you're going to a managed care organization, I think it may be challenging to have easy access to fluoroscopy. So I guess my point would be, is you've got someone like Dr. Ginsberg, who's working at one of the most highly specialized neurourology clinics in the country. And there are certainly elements where you're going to need these types of tools. I think the vast majority of the patients you can diagnose, as Dr. Nitti said, on examination, on history, using your thinking very critically about these patients and using the tools of native uroflow, simple systometrics, and multi-channel urodynamics to help you with the diagnosis. If you do need the fluoroscopy, you can, if you don't have it available to you, VCUGs, as Dr. Nitti pointed out, I think are going to be a really helpful tool. Or you can then refer out, as Dr. Nitti had commented.
Yeah, don't make the easy ones hard. And in fact, when you talk about things like prolapse, we just published a paper recently where, I think urodynamics in general in prolapse patients, unless you're looking for occult incontinence that you can't occult stress incontinence that you can't diagnose in another way, is not really that helpful at all. So we've really become very select in doing our urodynamics and trying to do them a lot of times we do them in cases that are a little bit more challenging. But as Chris said, don't make the easy ones difficult. Not at all. We showed you some complex ones because they're kind of fun to present. But if it's your garden variety of obstruction after a sling or prolapse, or even female urethral stricture or diverticulum, or, you know, even a fibroid that's pressing against the urethra, don't make it more complicated than it is.
Well,
kind of along that point, there were a few people who were kind of asking about obstruction after a sling, and would be interested to hear kind of your different perspectives on, you know, what criteria do you use in the PACU for passing avoiding trial? And, you know, does that vary by age? When do you repeat it as an outpatient? If they do fail, is that a week? Is that a few days? And, you know, what are your criteria for taking them back, and what kind of surgical approach? So a whole bunch of questions kind of grouped to one, but I know everyone has a little bit of a different approach. I think it'd be interesting to hear your perspectives.
Well, I certainly did a bunch of talking, so I'm going to let David and Chris opine on this one.
You want to start, Dave?
Sure. So, I mean, I think I'm going to start at actually the end when the patients can't void, because I know Vic had a slide on that, but I'm not sure that he emphasized an important point, which is if you can't void after a sling, or you have significant obstructive voiding symptoms after a sling, I think for the most part, as Vic was just alluding to, we've kind of moved away from doing urodynamics in those patients. You know what the problem is when the symptoms occurred after the sling. I don't need urodynamics to tell me the patient's obstructed, and that patient's going to get a sling incision, or if you want to try soon enough after a sling, some kind of adjustment. But those are patients that, at least in my practice, I've moved away from doing urodynamics on, because urodynamics really aren't going to change what we're going to do. I don't know if you guys have anything different to say on that, but I think that was a point that you had on your slide that I'm not sure that was appreciated on that. Chris, do you anything different on that?
Yeah, I mean, maybe I could speak globally. I think, Will, you brought up some of the questions that were coming up was sort of post-surgical management obstructive issues. And I think some of the things you brought up was everything from how do you manage the peri-op period to how do you sort of put the timer on and what's your endpoint, and perhaps maybe implied in the question, Will, was when are you going to do something about it? Yeah. So I would just say a couple of things. One is, I mean, observationally, and Vic, you talked about this a little earlier, the sling, the tension-free sling, the initial reason for that word was tension-free was that it's not fixed to anything. It's sitting in space. But I think we've come to apply tension-free as how we actually tension the suburethral portion. And the reason I even bring this up is it doesn't take much, as Dr. Nitti pointed out, to obstruct a female urethra, which is why probably most of you are doing them very loose. Dr. Rosenblatt, who may still be on the call, you know, he talked about a technique where he uses a knuckle using a Babcock to create a knuckle of mesh so that you can already put a safety net in there to not over tension these. And the point about this is it doesn't take much to obstruct a urethra. So before the patient goes home, to answer someone's question, is all of these patients, whether they're same-day surgery with the sling only or they're staying the night after reconstructive surgery, is they're getting some assessment of residual urine evaluation before they leave. I know some of my colleagues just send them home without an evaluation. So I do some PVR before they go. And the determination of what is the magic number, we can maybe talk about a little bit later. But and you can use a percentage of total voided volume, or you can use an absolute number. In general, I'll use an absolute number because it makes it easier on the nursing staff. And in our particular facility, we have lots of nurses working through it. So we could talk about what that magic number might be. But globally, if they are above that magic number of elevated residual, I'll keep those patients with bladder rest for a period of time, generally about 3 to 5 days, and then have them come back in the office to just do I'll pull the catheter, and I'll fill the catheter, and then check residual at that point. So that's the management. In terms of when I do something about it, it's rarely, because almost all of these resolve, particularly if you're not over tensioning. So I cannot tell you, we have not had to go back and release the sling or relax tension on the sling in years, because we're putting them in loose and we're allowing the patients to go through probably at least several weeks before we would think about going back. The ones you would have to do something about very early, in other words, when do I have to go back and take care of this, is if that patient can't pee at all, you can pretty much count that that patient is not going to ever meet a standard for adequate bladder emptying. And those
So
are
Chris,
if
a patient can't void at all, when are you gonna take her back in and incise the sling?
I don't wait very long. I might give them a few days, but if they still can't pee, then it's too tight.
Right. So then, are you incising it, or are you trying to manipulate it and loosen it?
All right, so I can answer this question. So it's really interesting. It doesn't take, the longer you wait, the harder it is to dislodge. So in just fresh cadavers, it only takes 2 or 3 pounds of pressure to take a sling and reset it out of position. In other words, it's not fixed yet. So it just takes a very small amount of pressure. So the earlier you do it, the more likely you're able to preserve the integrity of the sling and just pull it down and loosen it. So I would do it earlier than later.
What if the patient has really obstructive voiding symptoms, but she's still voiding? Is that a different scenario for you? Because to me, that's definitely different.
Because it could mean a couple of different things.
Well, I mean, because if she's voiding and she can wait, my concern is if I cut the sling, then recurrent stress incontinence occurs. But if I can wait longer and let a little more of that side of that sling scar or whatever is going to happen, maybe the likelihood of recurrent stress incontinence is less over time. I don't know if this is going to be true or not. Whereas if I cut that sling after a week, they're more likely to have recurrent stress incontinence. And, I don't know we have no idea if this is true or not. So if you can wait, is that going to make her less likely to have recurrent stress incontinence?
I was doing all the talking. Vic, do you have a comment about that?
I mean, my best answer to that question is I don't know. My gut feeling is that if you manipulate early, it probably increases the risk of recurrent stress incontinence, but that's based on anecdotal information. And as Chris said, I do believe that our incidence of needing to manipulate mid-urethral slings has gone down over the 2 decades that we've been doing them. It is a lot less. I remember years ago, if I had a woman in complete retention, I would give her the option to loosen it in the office, actually open up the vaginal incision and pull the sling down. I probably did that 4 or 5 times. And you can't do it much after a week, but I can't remember I've taken that slide out of my talk because it's been so long since I've done that. But actually cutting the sling, I think if you wait a little longer, it's probably better off, but again, I don't know. And a lot of times I'll let the patient make the call. And what oftentimes, if they're struggling to empty, but emptying, they'll usually wait it out. If they start to develop urgency incontinence, that's when they start to get a little bit more annoyed about it. I tell the patients that I think the sling's a little tight. It may loosen up. We may need to do something about it. And I remember a few years ago, I had a patient and I was very clear to her what the problem was from early on. She didn't need to catheterize, but she was struggling to void and had some urgency incontinence. And she made the call and she waited a year. And fortunately, once we took it down, her urgency went away. She didn't redevelop stress incontinence. But that's just between you and the patient. As long as the patient's not in trouble, you can, that's a shared decision issue as to if and when you're going to go back and manipulate, at least for me.
On that note, unfortunately, I do want to just kind of interject. Unfortunately we're out of time. It's already 11:30, but I do want to thank Dr. Nitti for a wonderful presentation and our panelists, Dr. Ginsberg and Dr. Tarnay. Great discussion, answered a lot of questions for us. I think it was really helpful and I hope it was very helpful for the audience. Again, I want to thank AUGS, SGS, and SUFU for putting together these informative webinars. Just a reminder, we are putting on these webinars every Tuesday and Friday, and the next one will be this upcoming Tuesday on the anatomy of level 3 support, surgery, prolapse, operative failure by Dr. Delancey. We look forward to seeing you all then. And again, please take the time to complete the feedback survey at the end of the session. See you next time and stay well. Thank you, everyone.
Thank you, Will.
Thanks, Will.